Hi, this is Dr. Nick Biasotto, your host to the podcast of the Medical Society of Delaware, Delaware Healthcare Reality. Just to let you know, we have three big events coming up for the Medical Society of Delaware. On October 18th, the Superhero for Hope 5K Health Fair and Food Drive will occur at Rockford Park. Keep that in mind. On October 23rd, as part of MSD's annual meeting week, a virtual CME program with this year's theme, The Body Connected Healthcare Wearables, will occur. And don't miss the 236th annual meeting of the Council session on October 25th with keynote speaker Stephen K. Klosko, MD, MBA, author and former president of Thomas Jefferson University, who will present Swifties, Startups, and the Singularity. For details for all of the three events, go to the MSD website at www.medicalsocietyofdelaware.org. That is, again, www.medicalsocietyofdelaware.org.
Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasotto, the host of your podcast, the Medical Society of Delaware, called Delaware Healthcare Reality. Today's conversation will be about vaccines. But before I introduce my guest, I would like to give you a little intro about how vaccines came about. Believe it or not, in the 10th century, the Chinese, who had developed a way to protect against smallpox, which is one of the most deadly diseases in human history. Now, how did it happen? Why it happened, how it happened, and who had the idea is I could not find in my research. But they used to take some of the scabs from individuals who had died from smallpox and pulverize them and inhale them. And it seemed to give some form of immunity to the individuals who hadn't. Now, that's the 10th century. Then we progressed up to now the 1700s, 1790s in particular, when a physician named Edward Jenner developed the first true vaccine. Dr. Jenner observed that milkmaids contracted a less deadly pox vaccine called cowpox. It gave them a slightly mild disease, and they continued to work. But he also noted that they had an immunity against smallpox, and that's when the first vaccine was developed. Then we proceed now to the 19th century when Pasteur developed vaccines against rabies and anthrax. Finally, and to this day, numerous vaccines have become a necessity to stop the starting or spreading of many deadly diseases. The podcast today will focus on all of the vaccines that I bring up, and such that it will be a way to understand how they work, understand what they protect you against, bringing in any moderate risks or benefits, or does the benefits outweigh the risks? There will be some controversy. And to discuss these vaccines today is a physician I have known and worked with for many years, Dr. Kirsten Hauer. She's an infectious disease specialist, and we worked for many years at the Wound Care Center and Hyperbaric Center for Christiana Care. She was our infectious disease go-to person, and believe me, we saw many infections in the Wound Care Center. Dr. Hauer graduated with her medical degree from Drexel University, Hahnemann University Medical College in Philadelphia. She then did her internal medicine residency at the Medical Center of Delaware, now Christiana Care, and its affiliation with Jefferson University Hospital. Then she did her infectious disease fellowship at Temple University. She has done numerous clinical trials studying mainly antibiotics, because that's her specialty, before they're released to the public to make sure that they're effective, they work, and they do what they say they would with least side effects. She has been associated with the Christiana Care Institute Hospital for many, many years. And presently, she's an infectious disease physician specialist and owner of the First State Infectious Disease Specialist, LLC. Welcome, Kirsten.
Thank you, Nick. Good to be here.
Okay. Now, I'd like to start with some of the controversies and oppositions to the use of vaccines, mainly going into the benefits and how the benefits outweigh the risk of taking them. Let's focus on commonly known vaccines and the benefits versus any risk. For example, diphtheria, pertussis, tetanus, commonly called DPT. Can you discuss a little bit about the DPT immunizations and what they've prevented and hopefully stopped, and that the risks are really, the benefits outweigh the risks significantly? Could you comment?
Yeah, I mean, this is a vaccine that goes back to, childhood initial immunizations and then sequential boosters depending on the risk an individual has encountered. The diphtheria is one very serious illness. The P is pertussis, and the AP is acellular pertussis, vaccine. And then the tetanus, which can be a very serious illness with neuromuscular debility and death. So.
I saw one tetanus in my life, and that was in my residency. I've seen pertussis, whooping cough in children. I don't remember seeing a diphtheria, so I'm kind of glad I haven't seen any of that. And basically, no major risks to taking that particular vaccine, except maybe a sore arm for a couple days, correct?
Exactly. You might hear some people say, I really had pain with that, but other than that, I haven't really heard of
anything worse.
Yeah, anything worse.
Now, here's one that's always been a controversy, is measles, mumps, and rubella, or commonly called the MMR. As you know, and as the public knows, there's a great fear that getting that vaccine will cause autism, and that was circulated by, I think, a Hollywood star who said that her son got autism shortly after receiving MMR vaccine. Well, as you know, and hopefully the public knows, this has been debunked and found to be false, that there is no connection between the MMR and the development of autism, though autism is seemingly rising in our country, maybe due to other reasons. But do you have any further comments on the MMR?
I would say the benefit far outweighs the risk, and it's why it's an important childhood vaccine, particularly looked at in school-age children, and having them protected before they're entering the school environment with a large population.
True. And now we're seeing the measles rise in our country, the disease measles, which can cause neurological damage and cause death, and is starting to rise in the population that isn't being immunized. We've had an influx of immigrants into this country, as you know, not immunized, who may be causing some of that to happen. We also have religious sects that say they don't want their vaccines to be given, and in those sects they run the risk of having their children develop measles. All, I think, through misinformation. And we see a lot of that today, a lot of that on the internet. People take what they read on Google and what they read in other things on the internet as gospel, and it changes their attitude towards trusting the medical fields and the government in working with the medical fields in protecting against these diseases. That's a shame.
Absolutely. I would agree. I mean, I would tell you that I think the whole world of IT has exposed people so rapidly into so many sources of information, and people have to remember to use some discretion and also have some respect for medical professionals who have worked with things like you have for years and see things. And in my fellowship, I did see a sweet little boy. He was about 2 years old, blonde-haired, blue-eyed, and from a religious sect. And on Friday they said, meet Johnny, whatever his name was, and he was a sweet little guy. He was congested and was having progressive respiratory congestion. And he was from a religious sect. He got measles and had not been vaccinated. And when I came back to that site the next week on Tuesday, I said, where's that little guy? And they said, he's gone. He had actually passed away. So I did have a direct experience that way. Also, the other thing I would want to say about measles is that it has an R0 of 18, and some of this will reflect to what we talk about with COVID. It's one of the most highly respiratory contagious illnesses. So if you have people in your society who are an increasingly immune compromised, all these people going on these imumabs and immune suppressive agents for inflammatory diseases, or people with cancers on chemotherapy who may have been vaccinated but may have lower immunity, due to their health status. And then you have other people in the population who, for whatever reason, immigrated from a country illegally, so they haven't really gone through the process that people who legally immigrate go through to make sure that people are vaccinated to protect themselves and each other. There can be an increased risk of exposure, I would say, to your base population. And measles has been spread. You can get it walking through Disneyland or an airport.
Yes.
Yeah.
Amazing. Very contagious.
Yeah.
Next is polio vaccine. One of our presidents, Franklin Delano Roosevelt, had polio. The development of the polio vaccine came with Salk and Sabin, who developed the vaccines for usage. I remember we used to get a little sugar cube, I believe, when I was younger. Now we're giving injections for it. I don't remember anybody having any major problems with that vaccine. Have you? And the polio vaccine is very effective in preventing polio.
Yeah, I haven't seen any major effects in my time or, experiences with the polio vaccine. And I think Sabin was the live attenuated, is how I recall it.
Yes.
But, yeah.
What's the difference between attenuated and live virus?
I think live attenuated, it's a weakened virus, but sometimes those were felt to be more immunogenic. And then some of the vaccines can be killed virus inactivated completely. Like you'll see flu, the flu vaccine, the inhaled they give the children is live attenuated. The injected is usually killed. There's also vaccines that now, with more sophistication, use a surface protein of the infection or a component of that. And so you're not even really, people may think they're always getting exposed to the whole infectious particle, but attenuated, and that's not true. A lot of times it's a surface antigen that has been found to promote immunity.
And so what happens is the immunity comes from these vaccines because a particle of the organism is put in the vaccine, correct?
Yeah.
And so it is given to you. And then your immune system tends to recognize it, build up against it, so that if the true virus is now exposed to you, your immune system is alerted to it and goes and prevents it from causing disease.
Exactly. And we talk about an anamnestic response where people have been immunized. Like say you got hepatitis B vaccine years ago and your titers may drift downward a little bit. But if you're re-exposed, there's often felt to be an anamnestic response where, okay, now the army comes forth and the immunity mounts.
So the your immune system recognizes it and takes care of it. Well, that's very good.
They still look for baseline levels of, they want to know what your Hep B titer is. Sometimes is it within that range that they feel it will mount the response. But it is more telltale if someone's been exposed, that they'll mount a higher response.
When I do, for example, I may have a patient with liver enzyme elevation and I want to do a workup for that, and I'll look for hepatitis C, which is one you do, and you look for hepatitis B. You were mentioning those. I look at the antigen, and because we're immunizing people against hepatitis B, I look for both the antigen and the antibody, and then it tells me in my report probably immune to the disorder because they've already received their hepatitis B vaccine.
Exactly.
Okay.
And the other thing is all the hepatitis B titers can get very confusing, but the core antibody means that somebody had actual infection. Yeah. You're right. And the surface antigen, if it's positive, there's still potentially a carrier and potentially contagious.
Okay.
But if they form the antibody, that's a good sign that they got the vaccine and had a good response.
Got it. We went off of polio. I got good. The next one's varicella or chickenpox.
Yeah.
I got chickenpox when I was a kid. The only thing it left me with was kind of a few scars here and there because I scratched the hell out of it. But I had a child in my practice who had varicella and ended up with a seizure disorder because it became an encephalopathy that the child had. He did okay.
Yeah.
He did okay. I immediately, when I saw him in the office, he had the seizure right in my office, shot him out to AI, and he did okay. But, that's a possible risk that this can happen. But that was from the disease itself. I've not had anybody have any problems with the varicella vaccine. Have you heard of any significant ones besides a sore arm?
I haven't heard of, some people have complained of feeling it worse when they get the second. And the other thing is there's the VZIG and there's the other zoster vaccine, anyone with immune compromise, like HIV patients, are not recommended to get the live attenuated, but to get the recombinant vaccine. And you're right, it's a very serious illness. I got called years ago, earlier in my practice, to a patient, a lady that was in active preterm labor, and they said, "Oh, she has varicella zoster," and I thought, well, maybe not.
Varicella zoster is shingles.
Varicella zoster is the chickenpox virus. Herpes zoster is referring to the shingles.
Herpes. Yeah, okay, got it.
So she had the varicella zoster, and literally I went in to examine her, and she had little vesicles popping up all over, literally, while I was interviewing her. And so we suppressed her labor, and she got, this is some years ago, she got 5 injections of VZIG, varicella zoster, acute immune globulin, and acyclovir, because the risk to a neonate, if the mom isn't immune and doesn't have antibody to confer protection to the infant, it can be very serious in the neonate. There's a mortality risk.
I understand. Yeah. Well, now we have the shingles vaccine, which sort of follows that, because shingles is a reoccurrence of varicella virus.
Yeah.
Generally producing severely painful rashes. And people have seen the commercials and people's faces and their arms and their legs all involved with that particular thing. It's good if you get it really early and you get on, antiviral medication, but it's still important to consider getting a shingles vaccine. I've had people get them, and they say it's painful. That was the only side effect I've seen from shingles vaccine. I felt lousy for a couple of days because it hurt like hell.
Yeah.
But that's it, and it does have how much of a protection against shingles?
I don't know the response rate, but I think it's fairly protective against shingles, and the shingles happens because the virus hibernates in the dorsal root column, and so if it activates and it comes out along that nerve root, that's why it's often on like one side.
Correct.
Whether it's and my mother had it once at a T4 level, which is along the breast level, and post-zoster, she had a very painful neuropathy. Some of the worst cases of shingles that I've seen are when they go over the eye or around the ear, and then they can cause problems with the vision or problems with hearing and permanent deficits. But it also can leave a very painful, sensitive area. She didn't want to wear certain clothing, or even a bra, because it was tender in that site, even long after the outbreak.
Well, I have a personal story about that, too. My daughter got the shingles, and it was one-sided, diagnosed as shingles. Rarely, and this was a rare case, it jumped to the other side.
Yeah, it can.
It's rare, and I spoke to the neurologist that saw her, and she says, I've only seen one other case in all my years of it doing that. So it did jump to the other side, causing her a neuropathy-like pain, nerve pain, for which she did okay on gabapentin. But it does show that this potentially can jump the cord.
It can.
Very rarely, but it can. Let's go to the HPV vaccine.
Okay.
Now, human papilloma.
Before you do, hang on a second. Do you need any more shingles-related stuff? I'm a walking, had it and got it over with.
You can say.
One of the best things that happened was I got a new eye doctor. And because he was... you know the name Pecos Olurin?
Yeah, Olurin.
Yeah.
Olurin.
Yeah.
Oh, okay.
Pecos Olurin.
Yeah. Found him through the first aid station out on Kirkwood Highway. And I had it right over my eye. And of course, I use my eyes in my work. But the other, and so just for if you need any more reference to that, but it sounds like you wrapped it up.
Okay.
The one thing I heard though when we were talking about polio, you said about the sugar cube.
Yes.
There was an injection before that, because I must be enough older than you that I got the injection.
Or it's where you worked, yeah.
And I know. Oh, but the other thing was for
smallpox. We don't get that
anymore.
anymore.
What's the one that creates the target on your arm?
Smallpox, yeah.
But we
I
don't
got
do
it.
that anymore because it was eradicated. I got it too.
Yeah.
They don't do that anymore.
Okay, I didn't know whether any of that was worth it, but if not, we'll just pick up from. You were just about to start a new subject line.
HPV.
Stand by, and when you're ready, go.
Well, what about the HPV vaccine, human papillomavirus? As you know, human papillomavirus is one of the chief causes of cervical cancer in a woman. And it's starting to rise as one of the top causes of oral cancers.
Yeah.
And tell me a little bit about that, because people are kind of worried about that. They don't want to seem to get it when I recommend it.
Oh, you mean the vaccine?
The vaccine, I'm sorry.
I think, it's it was coming out right around the time my daughter was of that age. It is an age-dependent vaccine, so if somebody puts it off too long, after a while it doesn't have the same protective effect. Plus, I guess some of that was felt related to immunity, but I would also say more to exposure, that because the whole concept of vaccines is preventive, you want a person to get these vaccines before they're at risk with sexual exposure. And so when my daughter was around, adolescent age, it was coming out, and I did have her get it. The second vaccine, sometimes when there's a vaccine series and there's more than one, the second or the latter vaccine will have more reaction. And they thought she was ready. They had her rest on the table for 15 minutes. She got up and passed out and went down on the floor. So that can happen. The initial vaccine that came out was bivalent, so it only covered for like 2 strains. But then the more recently, and I'd have to look at the year, but there's a 9-valent vaccine that covers 9 strains. So it really covers the majority of strains of HPV that have been found associated with these cancers. Yeah.
Wow. So a good vaccine to get.
I think so.
I get the same complaints. It hurt. That's
Yeah.
it. Getting it just got. That's your immune system. I mean, if you give one shot, your immune system's alerted. The second shot, the immune system goes nuts and says, "Wow, this is coming in," and they attack the area, which is generally the arm, and it hurts like the devil.
Exactly. And you're protecting someone from something they may not see coming, or a risk that may come to them in the future they can't realize.
I agree. Now, the flu vaccine, everybody knows the flu vaccine. But a lot of people tell me, it didn't do anything. I got the flu anyway. Okay. Tell me about that.
Well, the flu vaccine, I can't speak through every year, but I know that there were some periods where the vaccine was maybe 60% efficacy. So, yeah, it's not 100%. I had a transplant patient we saw in the hospital years ago, and they said, "Oh, he doesn't have the flu. He got the vaccine." And I said, "It looks like the flu," and he did have the flu. Okay. So people who are immune suppressed may not respond as well to the vaccine, or for whatever reason. We don't always know why. And also remember that we're studying the strains from year to year as there's a drift of immunogenicity of the virus. So, if it's later in the season, maybe it's not going to be as protective. Maybe you're going to start to see new strains coming through.
Okay. Now, I'd like to talk next about the COVID vaccine. But before we do, I'd like to take a break. And we have a few announcements to make during that break.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Welcome back. This is Dr. Biasotto again, speaking with Dr. Kirsten Hauer, our infectious disease specialist, about vaccines. We talked about many of the vaccines, Kirsten, and now I want to talk about one that seems to be the most controversial, and that is mRNA vaccines for COVID-19. A lot of people have been concerned about the potential dangers of taking this vaccine because of the side effects they've heard or read about. And when you look at some of the side effects of the pharmaceutical company making that vaccine, some of them are quite disturbing.
Yeah.
We've seen myocarditis, pericarditis. I have personally seen an amputation that could not be attributed to any coagulation difficulties. And there are others.
Yeah.
But the pharmaceutical companies that develop these have immunity towards being taken to court for any adverse effects. So I wonder, and I'm asking you, do you think the mRNA viruses were put out because of our problems with the endemic COVID, that we put them out too quickly before the research was completed and all of the side effects were discussed and found?
I think there's a point to that, what you're saying. I think that, as the pandemic was spreading from from countries. The United States wasn't the first place we saw it. And I actually learned from a nurse practitioner at Christiana Care that United Kingdom was doing the vaccine she had a sister who was practicing in the United Kingdom, and she said they were doing the COVID vaccine about a month before the U.S., which I thought was interesting because that would at least afford some information to be shared about, hey, did people really have problems with this? And obviously, our front line, our healthcare physicians and professionals, the nursing staff, the physicians, and those who were all going to be potentially seeing this, but there were certain areas that were more concentrated for exposure, and we really didn't, although there was just so much unknown because the pandemic came upon so rapidly, the spread of this virus was so rapid, there were some fatalities, so it was something that, yes, if you have a means of prevention, an ounce of prevention worth a pound of cure. We didn't have any cure at the time, and that was a whole other thing that happened in medicine during the course of this pandemic. But I think that, we tried to reach a balance of having some study and safety of the vaccine and getting it out there to try to protect people. And my feeling about it, too, is that change is the only constant, and there was fluctuation over the course of the pandemic that initially I think the virus was said to have, at least our infection control people, did a few very nice videos about this on the R0, the transmissibility of COVID. And with the first strain that we kind of saw was like an R0 of 2.5.
What do you mean R0?
2.5 times as contagious as the flu.
Okay, got it.
And then by the time we got to the Delta, it was like 5 or higher. And I think over time, the virus, I do feel it was a bioengineered virus. It was a virus that over time evolved and became more contagious, but fortunately less virulent. Mm-hmm. So I think that, the worst we saw in the hospital, and I was kind of tracking at our hospital what was being reported as to the number of cases of admission. It was actually the second winter, 21 to 22, where half of our 1,000 beds were COVID. And I had morgue carts passing me in the hallway in the course of the day. So people were dying. I have some statistics I pulled, but Delaware was supposedly the 4th highest state for deaths, but not necessarily. Really? I have to look whether it was per capita or total in the country. And the United States, I think, had. Oh, I saved this. Let me take a look here a minute.
Mm-hmm. I can stop if you want.
I think I got it, or whatever you can edit later. I have here that the United States. There were noted to be 103,436,829 cases of COVID, with 1,226,130 confirmed deaths. So that's like about roughly 1%. Mm-hmm. Although, so when you think about it, it's like, well, 1 in 100 or 1.3 in 100 are going to die. But, is that you? So you think about how the pandemic had everyone so freaked out, and there were all these mandates and politics, and it affected the economy, it affected students, it affected education, it affected so many areas. And then it says it says United States, the most of any country, and the 17th highest per capita worldwide. So there were other countries that didn't have as many deaths. They maybe were smaller countries, but had more cases per capita. And then the pandemic ranks as the deadliest disaster in our country's history, it says, from this information I had. Mm-hmm. California was noted as the highest number of deaths, 102,356. For some reason here, Colorado came up second with 14,522 deaths. Connecticut was 11,034 deaths. Delaware is listed in here as, I'm trying to get back to look at it here. Because we're a smaller state, and I have to go back to look, but I think it was under the 11,000. It was about, I think, 1,300. We noticed in our hospital, New York was so overwhelmed. Mm-hmm. We had patients coming down. Yeah, we had family. We brought our grandfather down and brought him to Christiana Hospital, or our hospitals in Delaware. So there were people moving as there were areas that were overwhelmed.
Well, I believe also it was bioengineered and escaped from a lab. That's my personal belief. I don't have actual proof to say it.
I agree.
Before you leave this, and I just have to do this, and I'll preface it by saying I'm a lifelong member of the fire rescue community.
Yeah.
Did you have, either personally or part of your group in dealing with COVID, did you have much, if any, opportunity to interface with folks who were delivering patients, the paramedics, firefighters, people who were
First responders.
the real first step, the real first?
I would, on occasion, like if I was in the ER and saw some of them, and certainly you're right, first line exposures. There were patients who were, I think, and that's the other thing to say is maybe by the time someone's an extremist and they're calling first responders, those folks really were in the fire of it, and they're probably more contagious at that point. But initially, at points of the pandemic, when it was so virulent, people could very rapidly deteriorate. And I got to a point where I did use the technology in our computer because you could track a person's vital signs, and you could watch their curve for their respiratory rate, their heart rate, their oxygen saturation. And when they start to go down a hill like a skier, it's once it would happen, the nurses would say that's it. Once they get past 3 liters of oxygen, there can be a very rapid decline, or that's a turning point where you're either turning it around. But yeah, and I mean, I think our emergency room, I don't know if first responders had this, but I think they had hazard pay. Mm-hmm. There were other physicians, infectious disease and pulmonary, we didn't get compensation for hazard, but we were preferentially exposed because we were the prescribing factions for innovative treatments as things evolved. I think that the monoclonal antibody that was given as an outpatient was open to prescription, but it was extremely limited. And in fact, I took care of a physician who died of COVID who missed the monoclonal antibody by 1 day. He couldn't get it as an outpatient. He was scheduled for it the next day, and he wound up in the hospital and had rapid progression, deterioration. But I would tell you that, in terms of the COVID and where it was in its course, it reached a point where I think there was an enhanced virulence and contagiousness or transmissibility, and then over time it's become,
attenuated.
Less. Yeah, it's more attenuated. It's because that's a good term. It's still fairly transmissible, I suppose, but there's more what we'd call herd immunity from everyone getting exposed or vaccinated, which was the goal of the vaccine. Correct. And there definitely was a period where when the virus was more virulent, that the vaccine was clearly protective, and you'd feel bad. There were people that were getting exposed. There were people that also weren't even considering a lot of infection control. There were all these heavy mandates and shutting down businesses. A lot of infection control is common sense, not necessarily to the extreme. But there were people who were like going to the gym and they were on chemotherapy for malignancy and they were getting COVID. We did after a while get to a point too where we could get the lab to send it out to public health and check to see what strains people had. I had one lady who had 5 different strains of COVID through all her exposures.
Wow. Okay. Now, we left off with me saying I'm a believer in the bioengineering of it and escape from the lab, and you said, yes, I agree. So then we're going to come in after that.
All right, do you need to say it again?
You want me to?
You can.
Just
okay.
To create a smooth move.
Okay. I'm a believer in the fact that it was bioengineered in a lab and it escaped the lab, and that's how it got to the world. I had COVID myself. It was a really bad cold. So I got it when it was probably attenuated or lessened. Now, there was study after study that showed that the children of certain ages seemed to have some kind of immunity against COVID, did not get COVID like adults did, especially those that were either had diseases or immune compromised. In the adult base.
Yeah,
now,
that's an interesting area. Go ahead.
Now,
I'm sorry.
I have a theory that I think. Do you agree that their children did not get them as much as the adults did?
Absolutely, and they did not have a severe disease.
Okay.
Yeah.
Now, my theory is not proven. I haven't read this anywhere, but I have a feeling. COVID is a coronavirus. The common cold is a coronavirus. They took the common cold virus and manipulated it to become very virulent and very deadly. Kids are constantly in school, blowing their nose, coughing, sneezing, getting colds, spreading the colds throughout the whole class, giving it to the teacher, yada, yada, yada. Being it's a coronavirus, and they're similar except for that part that is manipulated biochemically, could that be a reason why children did not get the disease as much as adults did?
Maybe. I don't know that, that they were checking antibodies. We know that it wasn't as severe because I actually had the first patient in Delaware that was documented with COVID, and it was a physician, and they had gone on a cruise to anyone for King Tut's remains, the Nile River in Egypt. And they said, well, we weren't in Italy. And I said, well, but you were right next to Iran, which was also very high on the list of exposure at that time. And this cruise ship actually knew they had COVID-infected passengers, and they didn't tell the other passengers coming on board because of they wanted the money. So they put these people on the cruise, and there were, I went to our infection control person while this case first got worked up, because initially the physician called me, literally I was walking out of what was our last live ID conference for a couple years, because COVID hit then. But, and they had just presented an algorithm for evaluating someone for COVID, but they said, use some discretion, don't call us unless... And I called, and within an hour I got this phone call from this person, and I'm calling the infection control person with it. And they set up the testing, and at that time the physician and his wife went to their physician the next morning, and things were arranged to do the testing, and their specimens were hand-delivered to the public health lab in Smyrna, Delaware. And by 1:30 p.m. they called me, and he was positive. She was negative. But so it just, when that happened, and I was going on call that weekend, and the stage was set, there was another physician going out of town that I was covering. So I went through the ICU to see, how bad was it, were things happening. And the ICU was controlled, and the director, Dr. Benninghoff, was sitting there, and he said, we're preparing for this. And at that point, they had a letter from the CEO of AI DuPont saying the children are not as severe. We have X number of ventilators. We're willing to give if you need more at the hospital. Wow. Fortunately, it didn't come to that, but things like this were in the works.
Well, that's interesting to note. Like I said, I've had COVID and I've had a cold. It was a bad cold. I took my isolation period and went back to work. I have patients whose husband has it. The wife never gets it. They both had the same amount of shots, or they didn't have the same, they didn't get the shots at all. It's odd. And I said, well, beware that if husband has it, wife, you may get it too. So there is a medication out there called Paxlovid, you know that.
Yeah.
And that I used only if the patient had other immune compromised conditions. I usually, recently, this is when it first started, and I will use Paxlovid in those individuals because they're at risk of something else going down. And on the other people, I simply say, treat your symptoms. NyQuil, Dayquil, Advil, whatever you need to control your temperature and your body aches and the feeling that you cough and cold. And they do very well. They get over it, as I did. Now, off the subject of COVID, and this is the last question I'm going to ask you. There are arguments out there about the dislike of a mandate, number one, the government mandate. Number two, and there's also a favorable feeling from, not a favorable one, but where I have freedom of choice to choose what I want. Patient autonomy is very important. If a patient comes to me and says, I don't want to get it, I don't force them to. They have freedom of choice.
Correct.
But what about these religious sects, for example, that don't? And then they get the disease and spread it to the rest of the people. But if the rest of the people are immunized, they're controlled. But if the religious sect does not participate in immunizations, they get the disease and it spreads throughout their community. Are those reasonable objections to getting immunizations in your mind?
That's a difficult area. I mean, I think that, there's got to be a balance. I think that historically our world and our civilization and our societies have had it. And even when you look at, the Advisory Committee for Immunization Practices, the ACIP under the CDC, historically they've always kind of made, this is a standard of care. These are recommendations for vaccination. Not 1,000 out of 1,000 people would have every single vaccine when you start to get into the more slightly extraneous, like maybe not everyone's getting the zoster vaccine, though it's being very heavily promoted and more people are taking it. But I would say to you that along those lines, mandate was a new term for a government to mandate things, and that's what makes me think of, like, forgive me, communist China. Mm-hmm. It makes you think of communist countries where people have no choice, and it's difficult because you want a balance of protecting your population, but you also want a balance of freedom where you don't have a tyrannical government that's telling everyone, this is, the refrigerator you're going to have, the stove you're going to have. You can't use this coolant. You can't this, you can't that. And after a while, you can create more and more hardships for people where they're just simply under government control. And it can happen in an insidious fashion where after a while they don't even realize, but they're really it's a tyrannical government. Mm-hmm. You have someone telling you can't have wood-burning pizza ovens in New York, but they're flying private jets all over the world. So because of what? The green climate. I don't want to get too political here, but I'm just going to say.
We're not in on the green climate
but
stuff today.
Yeah. And part of the suspicion of the bioengineering is that there had been some work on this virus, and then to my recollection, it was termed illegal under the one administration to not do bioengineering of viruses as like a biowarfare. Mm-hmm. And then from what my understanding is, there was transmission of NIH funds to Wuhan, China, mm-hmm. where there was ongoing research. Correct. I will also say that at one point in the pandemic, there was a university, I don't know that I can name it, but it was north of here, mm-hmm. That somewhat bragged at one point that they weren't bioengineering, but they used another term, that they were creating another version of COVID that killed 80% of the mice. And, when you hear that and you're a health professional taking care of people with this disease and you are seeing people suffer and die, that's incredibly upsetting. Even though I was up late many nights during COVID with all the work that we had to do, I, at 2:00 in the morning, was emailing them about that.
Right.
And it was taken down the next day from that university. I actually had trouble contacting them, but I got through to their admissions committee.
So what do you do with that person who says, I have freedom of choice, doctor. I really don't want to get this vaccine. Will you be mad at me?
I will tell them, if you're not going to take the vaccine, at least try to modulate your behavior to protect yourself and others, and do it of your own accord. Uh-huh. You should mask, and please, if you're on chemotherapy, don't go to the gym and try to work out where everyone's doing all this heavy breathing and can be contagious before they're quite symptomatic. And so to take precautions for yourself and others. It becomes, I guess, a little more of a dilemma depending what's happening in your society. Mm-hmm. If people are not being as considerate of each other or potentially harming each other, but, in different ways and in considerations. But you also need a balance that I think you hopefully do have a democracy, a republic with some freedom, and the ability to work within that of consideration of each other and yourself to protect yourself.
Good. Mm-hmm. I fully am supportive of vaccinations. I have a question about personally about mRNA viruses. I think we need to do a little bit of vaccines, rather. I think we do a little bit more research in that area.
Absolutely.
And I thank you for a very intellectual and very stimulating conversation. I appreciate you being here.
Thank you.
You've always been a good mentor to me when it comes to infectious disease, and I particularly relied upon you so many times. Oh. But I think we're done for the moment, and this is Dr. Nick Biasotto signing off. Keep on listening. Any of those who have any questions, concerns, comments, or anything even to suggest a future podcast, please inform us on our healthcare.reality at medsocdel.org. We'll be glad to answer your questions. We'll be glad to take your suggestions. And everybody out there, thanks again for listening.
Yeah.
Fini.
Okay.
Thank you.
Good.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Minton. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.